Okay, we haven't talked about an ectopic pregnancy in a while. Ectopic, Latin. So Latin for outside of the place. Top means place, ect means outside. The place in this situation is the uterus, right? So sometimes women will have a pregnancy. I assume many of you know this, but if you don't, the pregnancy should be in the uterine lining, and some women will have a pregnancy that grows outside of the uterine lining. The most common place would be in the tube. But occasionally you will have a PUO, pregnancy of unknown origin, meaning we don't see it in the tube, we can't prove it's in the tube, and therefore we know it's somewhere in the body, we just don't know where. So we're not necessarily going to talk about the extent of regular PUOs, meaning where we don't know where it is. We're really going to talk about ectopics mostly in the tube for the purposes of today's discussion. Let's talk about a classic scenario. You've peed on your stick. Maybe you've peed on 5 sticks because that seems to be the average that most of us do as women. You see that it's positive. You've just missed your period. It's a positive test. And you call your doctor's office. You're going to go in for your first visit around 8-ish weeks. And then all of a sudden you have spotting or bleeding or pain. And here's what I describe to patients. Spotting, bleeding, or pain, especially on one side or the other. And I'm saying pain in quotes because cramps like a period, very common. That little embryo is burrowing inside the uterine lining, and therefore a little bit of cramping is very common. But if it is true pain or pain that's more on one side than the other, and if you're just not sure and you're kind of questioning it, I would personally say always best to call your doctor. And certainly even spotting in the absence of pain, I personally would say call your doctor, because the majority of the time it is not something bad, wrong, concerning, meaning it's likely not a miscarriage, it's likely not an ectopic pregnancy, but it could be. Because is it normal to have spotting, bleeding, or pain in the early parts of pregnancy? Many doctors might say yes. I would say this is a matter of semantics. To me, normal is what should happen, whereas common is what often does happen. Normal to me is that you might have cramps like a period because the pregnancy is burrowing into the uterine lining. Common is that you might spot or bleed and that you might have pain on one side or the other for other reasons. But it's not what should happen, and therefore we should investigate it because occasionally that embryo has burrowed into the wrong place. So let's just review what happens when you have sex and how you get pregnant, because this is the important part to discuss with an ectopic. Here's my little picture. So this is your vagina, a picture that a penis has gone into there and the sperm has gone up into the uterine lining. And I should also mention that you might have gotten pregnant without a penis. You might have just had sperm from either you actually can get a sperm donor and use one of those kits where you inject yourself with an insemination kit at home, or you've gone to a fertility specialist and they've used an insemination kit that looks kind of like a syringe with a special tip that goes up into the uterine lining. Or you might actually have done in vitro fertilization where they've actually put the embryo into the uterine lining, and that still occasionally will lead to an ectopic. But for the purpose of today, we're going to say sperm. So sperm, especially when someone has had sperm, not from a syringe, but from an ejaculation, it will shoot up in here. And then once the ejaculate has shot up into the uterine lining, it typically shoots up through the cervix where there's cervical mucus that helps draw it up even more. And then the majority of the sperm is up into the uterine lining and it goes out to the tubes where it tries to meet the egg. These are the tubes, and the tube tries to grab through those little fingers at the end that we call fimbria, tries to grab the egg from the ovary. The ovary and the tube are not attached. Let me be clear about that. The ovary is not attached to the tube. The fimbria, the little fingers on the edge of the tube, are flying free, and they actually understand through a different chemical reaction to be near that ovary. And when that ovary pops an egg off of its surface, then the tube catches it, the egg is sitting in there, and then the sperm meets it. And then they create what is called an embryo. So the egg and the sperm meet in the tube, they create the embryo, and then they need to travel back into the uterine lining to burrow into the wall of the uterus to create the pregnancy, okay? Now, let's say the egg and the sperm meet, and they're both tiny, but when they create the embryo, they're together and they're a little bit bigger. Now they can't come back into the uterus sometimes because there's the teeniest bit of scar tissue or that little opening is just strictured a little bit. So they can't make their way back. So they get stuck here in the tube and they start to grow. And that tube is small, it's teeny. So when something is growing in it, it can hurt, it can be dangerous, okay? So when it grows inside the tube, unfortunately, it can't be salvaged, unlike some politicians and some, actually, Republican politicians have said you could try to remove the ectopic and transplant it into the uterus. That is impossible because it's embedded into the wall of the tube. It can grow, and as you can guess, there are blood vessels in that tube. Besides being painful, it can grow and it can burst. And it actually can be very dangerous, and I don't want to sound inflammatory, but back in the day where we didn't have the opportunity to find ectopics early, it was a source of very dire harm to women because when that burst and the blood vessels burst, women unfortunately could hemorrhage and pass. Nowadays, that's rare, especially in developed countries where we are able to detect ectopics really early. So if you have spotting or pain, why would you have spotting? Because you still develop a reaction in the uterine lining called a decidual reaction from that little embryo growing in the tube. So when the embryo grows in the tube, you are still sending signals to your body. The HCG hormone is still getting secreted, and a decidual reaction is still growing in here, but it's not quite the correct reaction of the uterine lining that has an embryo in it. So you still might get a little bit of spotting, and then your doctor would draw your blood. Your HCG hormone, she'll be able to detect the hormone level of the HCG, and then 2 days later, she'll be able to see if that HCG has done an appropriate rise. That's one way she'll be able to tell about an ectopic. Another part that she'll use to figure out this puzzle, because it's not always obvious, is the progesterone level. Progesterone, when it's under a certain number, can also be indicative of an ectopic, or certainly at least just a non-viable pregnancy. And third is a physical exam. So she will do an exam where she pushes on your uterus by doing a bimanual, where she puts one hand into your vagina and one on your stomach to push and see if there is pain, and more importantly, an ultrasound, typically a transvaginal ultrasound, to look for signs of this. Sometimes we will see the actual pregnancy, occasionally with a heartbeat, but sometimes just a mass that is growing on the side of the uterus where we will actually see the tube being distended. We typically would not see the tube on an ultrasound, but if it's distended with an ectopic, we will. So our course of events typically is, I'm spotting, I'm bleeding. Okay, please come into our office, and we will do an ultrasound to look and do blood work. If it's obvious right then and there, then we have a discussion about we think this is an ectopic. Often it's not obvious right then and there because you still may be early in your pregnancy where we have to do more discernment to understand what's going on. And if you are stable, meaning you're not in a lot of pain, you don't have any sign where you're hemorrhaging, then we give you precautions and we say, here's what we're worried about. It could be an ectopic. We're going to wait for the blood test. We don't see any obvious sign of an ectopic. We're going to see what happens to the blood work in 48 hours. These are your precautions. If you have pain, you call us. 48 hours later, if your HCG level does not go up by a certain percent, and typically we say that within 48 hours, we used to say it should double in 48 hours. Then all the data said really as long as it goes up by 50% in 48 hours. And now some of the data would actually maybe even argue that in the absence of obvious signs of an ectopic, you could maybe tolerate a rise of 30 to 40% in 48 hours. Then we would keep waiting and watching because we're hoping to see signs of an intrauterine pregnancy instead of something outside in the tube. So we would wait and watch and have constant surveillance with the patient. This is the time where it's really important to have a good collaborative explanation and discussion and relationship with your doctor so that you know what she's thinking and she understands that you know when to call, okay? So you go to the doctor, ultrasound, blood work. If it's not obvious right then and there, then typically 2 days later you would have another set of blood tests, knowing that at each given day, things might change. Let's assume you then get diagnosed with an ectopic. One of two ways, meaning either the numbers keep going in the direction that doesn't make sense, meaning the HCG level goes up, but not in an appropriate way, meaning it's only going up just a little bit, and they never see anything in the tube. Then we say, this is probably an ectopic or pregnancy of unknown origin, and then we have to treat it like an ectopic to keep you safe. And we would typically talk about a shot of a medication called Methotrexate, which, yes, if you Google it, is a chemotherapy medication or a medication we use in the rheumatology world for things like lupus or rheumatoid arthritis often. And in a single shot dose, or occasionally 2 shots, it's very safe. So please don't be scared off when you hear that it's chemotherapy. It's really just meant to stop the dividing cells. the dividing cells being an embryo growing somewhere it shouldn't be growing. If they see that it's actually an ectopic and they've diagnosed it because they actually visualize the growth in the tube, then the choices are either the methotrexate or surgery, and that will be based on a couple of different things. Are you in pain? How big is the mass? How high is your HCG level? Are you stable with regard to internal bleeding and things like that? And are you in a position where you want to take the chance of either doing the follow-up with the medication versus doing something definitive like surgery? Anytime you can avoid surgery, of course, it seems wise to do that. But a lot can go into that decision, and that's something that is important for you and your doctor to decide together, again, based on multiple different factors, okay? So yes, ectopics are something that have to be taken very seriously, but ectopics are absolutely something that can be managed, that can be detected, but they require surveillance, good collaborative discussion with your doctor, and you as the patient understanding and being compliant about when the doctor tells you to come in. Okay, hope that makes sense. I'm going to sign off.